Hematological features of systemic disease. Anemia of chronic disease. The picture is usually of a normocytic normochromic anemia. See Table 21 for differential diagnosis. Ordinarily there is a low serum iron and total iron binding capacity. In more severe cases, a microcytic hypochromic picture may develop. Iron stores in the marrow are normal but incorporation into erythroblasts is defective. The underlying reason for this is probably due to loss of erythropoietin sensitivity, which may relate to release of cytokines such as tumor necrosis factor alpha. Erythropoietin in pharmacological doses may be of some benefit, whereas the effect is dramatic in the anemia of uremia, due to reduced renal production of erythropoietin. Better disease control with immunomodulatory drugs may improve the hemoglobin. Note that ferritin, globulins, and erythrocyte sedimentation rate may all be raised as a feature of the chronic disease process. Any condition associated with prolonged inflammation, infection, or malignancy can produce this type of anemia. Key examples are rheumatoid arthritis and Crohn's disease. Liver disease. Chronic liver disease is often associated with a raised mean corpuscular volume, MCV, target cells, mild anemia, and thrombocytopenia. Acanthocytes, spur cells, and echinocytes, Burr cells, which are smaller and with more spikes, are also features of advancing liver disease. Zieve syndrome occurs following acute alcohol poisoning, producing hemolysis and red cell damage due to hyperlipidemia and changes within the red cell membrane. Alcohol excess frequently suppresses platelet production, which recovers during abstinence. This thrombocytopenia is not steroid sensitive and can cause problems for liver biopsy. Hypersplenism suppresses all blood elements due to dilution/pooling of the circulating volume by the enlarged spleen. However, do not miss a hematinic deficiency as a cause of pancytopenia in these patients. The diagnosis of hypersplenism requires a marrow of normal cellularity with an enlarged spleen. Clotting disorders in liver disease are dealt with under acquired bleeding disorders. Hyposplenism. The extremes of age are associated with relative hyposplenism. This causes a relative immunodeficiency and reduction in the response of antibodies to infection. Splenectomy may be performed during laparotomy for tumor or trauma. The spleen may be infiltrated by amyloid, lymphoma, or sarcoid. The spleen frequently atrophies in celiac disease, inflammatory bowel disease and systemic lupus erythematosus, SLE. Infarction of the spleen occurs in sickle cell anemia, and massive splenomegaly may be due to hemic malignancy, including chronic myeloid leukemia and myelofibrosis. These causes result in reduced splenic function, which may be seen on the FBC as leukocytosis and thrombocythemia. Target cells, acanthocytes, and Howell-Jolly bodies, Fig 38, appear on the film as a result of the spleen not functioning properly. Myelocytes and normoblasts may also be seen. Patients with a non-functioning spleen or who have had a splenectomy should receive phenoxymetyl penicillin V, or, if they are allergic, a suitable alternative for life, and should carry a card in the event of an accident. Vaccination with pneumovax, polysaccharide, and meningococcal and Haemophilus influenza B vaccines will improve immunity. Where possible, this should be performed 4 weeks prior to splenectomy to maximize the antibody response. Revaccination should occur every 5-10 years. Pneumococcal antibody levels will prove helpful in this decision. NB. Do not underestimate the seriousness of infections following splenectomy. Even fit young adults can die with an overwhelming post-splenectomy infection. Drugs. Many drugs can produce an oxidative stress to the red cell and produce hemolysis in patients with glucose 6-phosphate dehydrogenase deficiency. However, people with normal enzyme levels can also suffer from oxidative damage to red cells during periods of extreme ill health. Drugs can also be associated with antibody formation and a positive Coombs hemolysis. The commonest problem caused by drugs is mild cytopenia, S. Nearly every drug has been described as producing a blood dyscrasia, even if only in a single idiosyncratic case report. A decision has to be made about whether to stop the drug and see if the blood count improves, usually within 1-2 weeks, or tolerate a mild cytopenia, S, because the overall benefit of the drug outweighs the mild toxicity, e.g. anticonvulsants. Sometimes, a brief course of granulocyte colony stimulating factor may help during periods of neutropenic sepsis. NB. Some drugs, such as carbamazole, phenytoin, and methotrexate, are well recognized as causing marrow damage. Always be vigilant with patients who are taking such medication long-term. Drugs associated with aplastic anemia or cytopenias include antithyroids, carbamazole and propylthiouracil, antipsychotics, chlorpromazine, anticonvulsants, phenytoin, antibiotics, chloramphenicol and sulfonamides, anti-inflammatories, phenylbutazone, gold, and indomethacin. Macrocytosis. Several conditions cause a raised MCV without a megaloblastic marrow. Always consider the following: alcohol and liver disease, pregnancy, hypothyroidism, chronic obstructive airways disease, reticulocytosis, hemorrhage or hemolysis, scurvy. Alterations in the white cell count. Variations in elements of the white cell count occur frequently. Tables 22-26 highlight the common situations.